Hello, hello. Good to see you all. Okay, let's see. Look like people are popping in perfectly. All right. Well, good afternoon, and thank you all for joining us for this important Health Professions Educators Series Health System Science Open Forum session. Today's presenter is joining us to help enhance our patients' health literacy using universal health literacy approaches. So Dr. Kathleen Porter is a PhD trained registered dietitian and behavioral scientist. She's an assistant professor in the Department of Public Health Sciences at the University of Virginia School of Medicine. She is also an affiliate of the UVA Cancer Center. The overarching goal of Dr. Porter's program of research is to reduce cancer disparities and improve population health in rural and other health disparate communities by fostering the implementation of evidence-based interventions that address energy balance, related behaviors and outcomes, as well as cancer control priorities. So specifically, she has a growing program of independent research related to rural cancer survivorship, and she contributes to trials as a qualitative methodologist and implementation scientist. Dr. Porter also studies the application of universal health literacy precautions in community-based settings. So Dr. Porter, I'm going to go ahead and turn the floor over to you now. Thank you so much for joining us.
Thank you. Happy to be here. So just a quick, even with that bio, I really do always like to make clear why I'm talking to you about health literacy, especially within the context of a healthcare organizations and a lot of you being medical educators. I do a lot of behavioral intervention work, but really what's always at the heart of what I'm doing is the consideration of health literacy and the incorporation of these health literacy universal precautions. And so I'm very involved, as I just said, kind of really utilizing these in the real world, but I'm also very interested in understanding how they get implemented and really assessing and trying to figure out ways that we can make them better and more efficient. And so I really think that that plays nicely into today's presentation. And also, just to be, I guess, fully clear on this, I have no conflicts of interest to declare, so sort of from that standard financial piece. But I do want to share, my husband is a Carilion employee, and although I work for UVA, I'm actually located in Christiansburg, so I am actually a Carilion patient as well. And while that obviously does not bias what I'm going to say here, is going to put some of the things that I talk about in context. When I use health literacy and talk about health literacy as an example, I tend to talk about myself and use how even someone in my position, when I'm in a medical setting, how the health literacy conversation really does matter, even with my educational background. I am also going to be turning off my video when I'm really actively engaged in the slides. So just in case I wind up having any bandwidth issues. So I'm going to be turning that off right now. So as we get started, one thing I really do want to bring up is that this is the schematic that you all have been using throughout this training series. And when we think about health literacy, a lot of the times we kind of get stuck or limit ourselves to really thinking, well, this is something that's at the patient or the family or the community level, because it's something that we really consider as being a demographic variable. But what I'm hoping you'll be able to see through today's presentation is that health literacy is something that's much broader and that really touches all of these wider pieces that actually influence the patient, the family, and the community. And so really health literacy is as much about interaction and communication between the patient and the provider, the patient and any other clinician she or he may be interacting with, as much as it is about their individual needs as patients. And so with all of this being said, the objectives of today's presentations really would hope that you all are going to be able to walk away recognizing the impact that health literacy has on patients' behaviors and health. And many of you are probably already well versed in this anyway. Identify the different types of literacy that influence health literacy, really come to appreciate the importance of a universal health literacy approach, identify strategies to enhance patient health literacy at the patient, clinician, and organizational levels. And this fourth bullet is really where we're going to be spending most of our time. And also towards the end, really want to present and have you be able to walk away being able to describe the attributes of a health literate organization. And so what I'll be doing is at sort of stopping points along the way that are natural stopping points, just stopping to pause and to see if anybody has any questions or thoughts as we are going through. So that way we're not saving all the questions towards the end. So if anybody has anything, feel free to just either chime right in or add something into the chat at this point. And if not, I'll just kind of do my usual, I'll count to 10. And if I don't hear anything or see anything by then, I will move ahead to the next section. So I want to start off with a joke. It's a bit of a punny joke. Kind of was working on this over Father's Day weekend, so a punny joke seemed to have made sense. A woman walks into her doctor's office. She's a little overweight, so her doctor puts her on a diet. He tells her, I want you to eat regularly for 2 days, then skip a day, and repeat this procedure for 2 weeks. The next time I see you, you'll have lost at least 5 pounds. The woman returns in 2 weeks, and she's lost nearly 20 pounds. Doctor's amazed, just wondering, you followed my instructions, correct? And she nods, and she goes, I tell you though, I thought I was going to drop dead that 3rd day. From hunger? Asked the doctor. Nope, from all the skipping. So we're going to come back to this, but kind of a joke, just kind of thinking through of what a patient caregiver interaction might lead to. And before we go back to that though, really kind of pinching us into what is health literacy. And we think about health literacy at 2 levels, personal and organizational. And the definition that many of us see, the most common one, is this one that the CDC promotes. It's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services that are needed to make appropriate health decisions. However, the more you really dig into health literacy and dig into the definitions, you realize how multidimensional it is and how many different individual and systems level factors really influence it. And this model comes from a systematic review conducted by Sorensen and colleagues back in 2012. And really that we're able to see is that there's situational determinants, personal determinants, as well as how they're engaging in their healthcare system, the costs, their outcome, their personal sense of empowerment, issues around equity. And that all also shifts whether it's in a healthcare setting, if it's related to disease prevention or health promotion. So there's a lot going on that influences personal health literacy. And a more recent review that was conducted really looked at, well, what are these key elements of health literacy? And one of them obviously is knowledge, but it's not just knowledge of health, it's knowledge of healthcare in general, but also navigating those health systems. It also includes things related to processing and using information in various formats related to both health and engaging with the healthcare process. And so the information that it really considers are written instructions, oral communications, but also numerical information and how that's used. But then as we're getting more and more into our heavily electronic-based age with all of our social media, but also we need to also consider electronic information, but also how folks engage with media related to health information. Also thinking about how folks are confident in their ability to process and utilize health information, where that health information is coming from, and where and what can actually be accessed. And also their ability to engage in self-management behaviors. And with that whole larger picture, a new definition probably is emerging, and I will say there is no consensus on what the definition of health literacy is, but this is one that I just take as being a little bit more all-encompassing than the one that we tend to go by, is that it looks at the the same things that we were talking about, the ability of an individual to obtain and translate knowledge and information, but they're able to do it in a way that's appropriate to the individual and systems context. So really understanding that all of this is happening within a larger context. And our organizational health literacy is looking at how organizations are able to make someone be able to capitalize as much as possible on their personal health literacy. I have two definitions here, one that's used by the CDC, one that's used by the Institute of Medicine. And you can see that, put them up here because again, we don't have complete consensus on this, but you can see that they're relatively aligned. And when we go back to this idea of personal health literacy, we have no recent national numbers. Health literacy is not something that we capture on NHANES or we capture through BRFS. It is nowhere. And the numbers that we tend to cite and what we tend to say is that nearly 9 in 10 adults have difficulty using everyday health information. This number comes from a report that was a research trial that was conducted in 2003. In 2003, I was still in college. So that was an incredibly long time ago and something that was published in 2006. But that's what we cite consistently with our data around health literacy. And we also know that 40% of patients with low functional health literacy, they admit feeling shame. So number one, we know a lot of people may have difficulty using this information and that a good proportion of those individuals feel shameful that they don't know how to use this information. And then even further so is that we know that someone's health literacy is a stronger predictor of their health than measures that we tend to use as standard proxies: age, income, employment status, education level, and race. And this is how it really can drive our poorer health outcomes. We see someone who's has lower health literacy. We know that they're less likely to be compliant with recommendations. They engage in less healthful behaviors. They're less likely to use their medications properly. And through all of this, they have difficulty managing their chronic conditions. Even before that, we may see that they're missing their appointments more frequently. They're not following through on their tests or their referrals, and they're actually having more ER visits than potentially well visits or kind of standard visits. And even before that, some of the things that we may be noticing with our patients is that they may be less likely to complete the forms in the office. They're not responding or engaging around written materials. They're not giving as strong of a coherent or sequential health history, and then they're asking fewer questions. And then all of this really drives it. We always think about this when we talk about health literacy and the impacts, but we can see that it goes back even to how the patients engage with us as a clinician or as a healthcare provider in our various settings, whether it's for care or in my case, a lot around prevention. And we know that through all of this, that the patient-provider interaction can really impact patient health literacy. And so if we go back to this joke, what actually happens is as we learn all of this, it goes less from the smiley, happy baby telling a joke to that baby who is very, very upset and probably a little inconsolable and really starting to wonder, well, what's so funny about a miscommunication that led to a patient who had an unhealthy weight loss? I'm not a medical provider, but I am trained as a dietitian. And I will tell you 20 pounds in 2 weeks is definitely not a good weight loss. A patient who is most likely embarrassed at themselves and frustrated at their doctor for the way that those encounters went. A doctor who's frustrated by their patient for not engaging with the medical recommendation that was shared. And what really it comes down to is a patient with a health condition who may or may not return for follow-up. And so with all of this, we can see that there's gaps in practice and research, and that there is a need to elevate the role of health professionals in how we address health literacy. And so one of these ways is to structure the delivery of care as if everyone may have limited health literacy. You can't tell by looking who has good health literacy or proficient health literacy and who doesn't. Literacy does not mean understanding. And a lot of times this has happened because we assume people can read, and we also assume that because somebody can read, they can do all the other facets that make up health literacy. One of the examples I like to give is, as we've mentioned, I do prevention programs related to cancer. A lot of what we focus on is sugary drinks. We had one woman in our trial who is actually a literacy coach at our local literacy volunteers organization. And when you actually looked at her health literacy scores, she was incredibly low because she could do all, she was very, very competent at the reading and the understanding, but she could not do the numeracy parts of it. We also know that anxiety can reduce the ability to manage health information. So regardless of somebody's literacy skills, numeracy skills, or even their education and their understanding of health, if you put somebody in a highly stressful situation, they may not be able to act on them in this situation. We also know that everyone benefits from clear communications. And so the way to do this and to structure this care is to integrate health literacy universal precautions into practice. And I really just want to stress as we're moving forward is that utilizing these strategies allows for clear communication with the patient and or their caregiver. It is not talking down to them or dumbing down the content. It is making sure that the content is understood. And we also know, and what's very important is that these strategies are acceptable across all health literacy levels. A few years ago, I was a co-investigator on a trial that was called the Talking Health trial, and we had embedded these precautions in different ways throughout our trial. And we found that our participants were equally satisfied with these health literacy components that we had included in here, regardless of their health literacy level. And this was a community-based trial. So we had everybody from college faculty members in the trial to folks who had not completed high school, and that we did not see any differences in there. And so what I'd really like to dig into for pretty much the remainder of this session is to talk with you about these health literacy universal precautions. And everything that I'm going to be talking to you today comes from this toolkit that is made by AHRQ. There's 21 overall tools in this toolkit that address 5 domains. A path to improvement was really something to start thinking about the organizational level and really how to move things through there. Spoken communication, written communication, patient self-management and empowerment, and then also supportive systems. However, before I really start digging into these, I wanted to just check in to see if folks have any questions or thoughts before we move ahead, or any needs.
Can we just unmute ourselves with a question?
Yes, Cheryl, that's completely fine. Yes.
One thing that occurs to me is whether or not this addresses sensory impairments. So you're talking about, health literacy and accessing and understanding information. Does it include addressing visual impairment and hearing impairment?
So I would say yes, it addresses, because all of that will impact how we communicate with someone and how we are able to make sure that they're understanding the information. I will say, however, as these tools are developed, they really do focus primarily on written and oral, but we can definitely bring in those other senses as I'm going through these examples related to, especially as you were saying, visual and hearing. Any other thoughts or questions that folks want to chime in as we move forward?
Yeah, and like Dr. Hartman did, feel free to unmute, or you can post your questions in the chat and we would be happy to relay those.
Yes, and the one that came in through the chat, and this is incredibly important, that health delivery is influenced by insurance coverage, the type and the, I'm going to say like appropriateness of the coverage, which really can make navigation quite difficult. And there are some strategies in the toolkit that can help with some of that navigation as well. And so I'm going to definitely jot that down. So as I'm going through these other examples, just to really kind of highlight on these questions and specific points that were brought up. All right, I'm gonna.
And Dr. Misra, you're unmuted. Did you have a question?
Yes, I did. And it's more of a comment, actually. It seems like this really hits the key point about the 3 pillars, because it's actually the care delivery. The care delivery is what we missed out on. In the past, it was like, was I a good clinician? Was I a good scientist? Did I give them the right information? And all of that stuff is great, but how does it actually translate to the care being delivered? And that's what that miscommunication showed. It showed that, we were great about saying, okay, you should do this, this, and this, but we didn't clarify that the message was understood properly.
Yes, and so I think a few of these tools are going to get into ways of clarifying if the messages are received and kind of providing some guidance for that. So I know that these sort of 5 domains are how AHRQ organizes them. I tend to think a little bit differently, and this is how I tend to think about the tools. There's tools that help assess, there's tools that help develop, and there's tools that help with engagement. And I think about engagement in terms of use. And so within assess, there's these tools that help us understand patient health literacy, exploring your health literacy practices. And you'll see I have your, as we move forward in the presentation, in italics. We can think about your in a few ways. It could be you as an individual clinician, you as educators, you as in working with your team of learners. It could be you as in the larger you of your clinic or unit, or it could be you as at the organizational level of Carillion. Assessing your patient's perceptions of your health literacy practices. When we think about developing, well, what are ways that you can improve your health literacy related skills? And then engaging. And so this is, again, within the presentation where we'll be spending most of our time, but this is how we integrate health literacy uniform precautions into practice and establishing yourself as a health literate organization. And again, you being a very broad and potentially very expansive you. So when we think about understanding patient health literacy, there's definitely strategies that can be used. One can just be talking with patients about their health literacy needs. And obviously a lot of that's going to depend on how many are you seeing and how it's done. Are you seeing your patient again? What type of practice are you in? Where you may be seeing your patient and really needing to develop that rapport with them and understanding their specific needs. And that might be very important, especially like thinking through the question earlier, if you have a patient who does have a visual or a hearing impairment, as well as what we would think of as more of our traditional literacy with being able to utilize written language and numbers. There's ways to administer health literacy measures formally or informally during potentially a visit. There are existing measures that are out there. There is the Realm, which was one of the first developed, and it's basically a patient word list. We've used that in some of our research. I think it has a number of limitations. And it doesn't really capture the holistic piece of health literacy. However, it is one that is quicker to use. There is the newest vital sign, which is actually a series of 6 questions based on answering that are centered around answering questions around a food label. It's a general health literacy one, but it also really addresses some nutrition topics as well. And then there is the TOLFLA, which is a much more comprehensive measure. And then there also is the CHEW Health Literacy Screener, which is a 3-item screener. Within my research, we tend to use the newest vital sign a lot within our measures packets once folks are enrolled in the trial, but we use a screener like the CHEW in a lot of our screeners so that we're understanding who's enrolling into our program. And also something like CHEW is very simple and actually could be with our other ones, potentially, this is a longer term thing, is embedding these health literacy questions within the your health record and figuring out how that could be incorporated so that you're aware of that at your patient visits. But also if you're doing any of this measuring the health literacy formally or informally during a visit, definitely documenting that in the patient's chart for moving forward. When we think about exploring your own health literacy practices, it could be simple as reflecting on how you communicate with patients, whether it's something that you're thinking about on yourself, talking with your team, talking with your group of learners as they're developing. There also is a tool within AHRQs, within this toolkit, where you're able to conduct a formal self-assessment and identify areas of your growth. And so it looks at how you're able to do a lot of different of these things. And it was developed for primary care. We've had good success actually adapting this for use in a public health setting. We actually, a graduate student, probably about 4 or 5 years ago, utilized this tool as the base and adapted it for use with our health departments and trying to understand how they were engaging with their clients. Assess patient perceptions of your health literacy related practices. I guess one thing that can be done here, real surface, is reviewing patient comments, whether formally through the organization or looking more informally on websites. I mean, they are mentioning how clear folks are there, but a more systematic way is to actually conduct a formal assessment. And there's tools through AHRQ here. There also is a health literacy responsiveness survey that was created specifically too. And just trying to figure out within this of what are they seeing? I mean, and this is just a standard questionnaire, but you could also really go deeper and sitting and meeting with groups of patients and really starting to understand what is their experience like and how is their experience meeting their needs. So before I move forward to start really talking about thinking about improving skills, are there any questions at this point?
So Dr. Porter, I was wondering, with your one slide back, when you have the different types of, maybe it was 2 slides back, sorry about that, the different types of assessment, how do you approach giving a patient like the word list? To me, that would seem sort of offensive to some degree, where the other screening tools look much more.
We did that a lot one-on-one. That was actually embedded into one of our research trials, and I was debating whether or not to put it in here. I just really wanted to show that there's different types.
Got it.
Was
okay.
one of the most awkward things
Sure.
I've had to do. One, because I mean, all of us are probably, I would say you guys have all graduated from medical school, the majority of you. I have a PhD. I would not be able to comfortably do this.
Right.
We don't realize how often we get into sight words. And there is a little bit of a, I would say like a classist, what I would call a classist piece on this, because things have to be pronounced correctly. Like technically, if somebody said diabetes, it was incorrect. Even though the intention's there.
Right.
Yeah, so that was pretty biased. And also we would go from doing the realm to doing the NVS with patients. And so they'd be stressed from that one and moving into something else.
Got it. Okay. Thank you. Yes, I was just looking for clarification.
Anyone else before I move ahead?
So it looks like there's a comment in the chat. Self-assessment of successful communication is necessarily biased. Are these ever completed by patients or staff about your communication?
About mine in specific?
Probably about the providers themselves.
Yeah.
Is that true, Deirdre? She may not have access.
Sorry, I had to find where the mute thing was. Yeah, I mean, I'm just wondering, you know, it's very easy to look. I can't tell you how many times I will sit with a coworker as we're speaking with either a patient or even just someone else, say in an interview or something like that. And people will speak and they think they're being clear in understanding. And I'm picking up on all kinds of things where I'm recognizing that the person that we're speaking to has no clue what we're talking about, even though we may think we're being clear. And so sometimes I think self-assessment can be, you know, it's biased. I mean, you think you're being clear. Have there been studies done at all where patients actually complete that assessment tool regarding their provider?
And so it's this one actually, so this is like this tool, so these, the AHRQ health literacy patient survey and the responsiveness survey, they're actually patient completed. And so
okay,
they're
well, the one
shorter, but they address the same domains, but they're shorter.
Okay, so it same domains as the one that's in the provider
Yes.
self-assessment one?
Yes.
Yeah, okay.
Yeah. And we're also going to talk through a few things as once we get into sort of this more engaged section of kind of ways to just kind of check in on yourself too during these conversations to make sure that you're being clear. I know I'll just say personally, because when you said I was like, I know that I'm not always the clearest person. And so that's why I actually jumped to that. And I know to check in with, that's why I have I know personally, I can get excited about things and I can talk very fast. And I also take for granted what people know, which is, I would say personally, why I've built in these check-in parts. And so you're going to see something similar in a few minutes that the AHRQ recommends.
Okay, great.
And so for you to start developing your own health literacy skills, if a self-assessment has been completed and it's been completed thoughtfully and with less bias than we would hope, creating a plan based off of that assessment. And that personal plan could be something that you as an individual complete, you complete again as a unit, and just really thinking that through. Or that plan can actually be taken where the self-assessments from clinicians across disciplines and patients can all be pulled together, and it could be something that the health system or the larger unit within the health system utilize to create a plan to improve their health literacy aspects. There also are different specific professional development activities that you can undergo and kind of like more trainings into ways to get CEUs. And so now what I'd really like to dig into is some of these actual practices. Some of it's going to be a little bit dry, kind of walking through what they say, but really thinking through what can be done to integrate these into your practice. And so first we have this engaging in practices that can support clear verbal communication, maybe a better way of doing this, but greeting patients warmly, making eye contact, listening carefully and making sure that it's clear that you're listening. And you all have probably heard using plain non-medical language, reflecting the patient's words, slowing down, but things that and I feel like these top four we think about a lot. And I think they've come pretty natural to us through a lot of our training. But one of the other things that we're not as always good at is focusing the content, being specific and concrete, and limiting and repeating content as much as possible using graphics and demonstrations. This can get to folks who might not have the best hearing or just are not good auditory learners, being able to see things done different ways, engaging the participant by encouraging questions and using the teach back method, which we'll be talking about in a second. And then this teach back method is I'm sure some of you may have heard of this before. The teach back method is it's growing to be a somewhat standardized way of really allowing the patient to speak back to you with what they've either learned or what they're going to be doing when they leave the appointment. And one of the easiest ways to embed this, and one of the more efficient ways to embed this, is to actually talk to them. Well, what are you going to be doing now that we've had this conversation? What are you going to be doing when you leave here? And so that they're able to go through either the recommendations that you've set for them, if they're having to change their diet, for example, or how they're going to utilize their medications. And I am going to try and play this short video that's from the NIDDK, just kind of demonstrating health literacy. I'm sorry, the teach back being used. It's a little awkward because neither of these gentlemen are actors, and you can tell that it's definitely something that's being screened, but it provides a good example of teach back being used.
The teach-back method. The teach-back helps you confirm that your patient understands what you are explaining. After explaining a plan or a concept, ask the patient to tell you back in their own words. Sometimes all it takes is the question, "What are you going to do when you get home?" Or, "Let's make sure I covered everything. Tell me what you're going to do." This video has 2 brief examples of using the teach-back method to give you a feel for how it works. The first example is adjusting the dose of insulin.
Well, I think there are two things that we need to talk about. Have we ever talked about what to do when you have a low blood sugar before?
No, sir.
Okay, well, we need to talk about that today.
Okay.
The other thing, so we want to talk about what happens when you get a low blood sugar.
Okay.
And then I want to talk about how can we keep you from having these low blood sugars again. All right. So the first thing I want to say is I want to cut back your morning insulin dose. I think you might be on a little bit too much.
Okay, yes, sir.
And so instead of 25 units, I'd like you to take 20 units in the morning.
Okay.
Okay?
All right.
And then how many do you take at night?
20.
20. Okay. So then how much will you be taking?
We 45.
45?
Mhm.
Okay. So tell me, break it down for me. Tell me how much you're going to take in the morning and how much in the evening.
If you're gonna break it down, I'll be taking 20 in the morning
Okay.
and 20 that evening.
Perfect. Okay. Exactly. That's what I want you to do.
Okay.
Okay.
The second example is adjusting the dose of blood pressure medicine.
Mr. Holt, I see that your blood pressure is still running a little bit high.
Yes, sir. I tried, but I took all my medicine, plus my blood pressure medicine. And when I came in for the visit this morning, the doctor gonna tell me my blood is high.
Okay. So we started you on this last visit, and we put you on 5 milligrams of lisinopril. Tell me, have you been able to take that every day?
I take it every day.
What time of day do you take it?
I take it early in the morning.
Early in the morning? Okay. Do you have any side effects from it?
No, sir.
No?
I don't have no side effects.
You don't feel lightheaded or anything like that?
Like sometimes I'll be walking, I get like a little dizzy sometimes. You know, I stop, you know.
Okay. Okay. Well, your blood pressure today was 155 over 88. And so I think we ought to go ahead and increase that medicine.
No, sir. That'd be fine.
And when did you have it filled last?
A day ago, just had it filled.
You just had it filled. This is your bottle right here. It's full. Okay, so these are 5 milligram tablets, and I think what we need to do is go ahead and put you on 10 milligrams.
Oh, okay. Okay, that's fine.
Since you just had this filled, what you can do is just take 2 tablets at a time.
Okay.
Okay? And you can take them together. You don't have to split them up. You just take 2 tablets in the morning instead of 1.
Okay.
All right. And then I'll give you a prescription for a bigger pill.
Oh, okay.
For when this runs out, it'll have 10 milligrams in the pill.
Okay.
Okay. So when you get the new pill, when you get the new prescription, you only have to take 1.
Okay. All right.
All right. So tell me how you're going to take this now.
Yeah. I'm gonna take 2 of them. If I take them one, take 2 pills. That'll be 10 milligrams.
Yeah.
Okay. Until I take all of them, I just go back and you distribute me to 1 pill. So I'll be taking 1 pill after I finish up this prescription.
That's right. That's exactly right. So you'll take 2 until this is done, and then you'll switch over to the new prescription, which is just 1 pill.
1 pill.
Perfect.
So that was an example just of 2 different ways of using TeachBack, and just trying to get the patient to really recall what their next steps are, not even recall, but really state what their next steps are going to be. Other techniques include, and this should have been deleted, of course, utilizing a brown bag medicine review, which really allows the patient and the clinician to go through all of their medications together and to understand how they're working together and to make sure that the patients are utilizing and taking their medications correctly. The next steps, their next tools really relate to engaging in steps that move you towards being able to practice cultural humility, really understanding and being able to address language differences, whether it's literally you do not speak the same language, you're working with somebody who is not proficient in English, or there's just differences in terminology and how we use words and just and how those different things happen, but also starting to consider how culture, customs, and belief may actually impact the ability of the health literacy of the individual. And then another really important one is to create and use written materials clearly. And I know you all are clinicians, you're not really going to be creating materials per se, but what you do have the ability to do is to look at the materials that are coming in and that you are using. And so finding ways to assess those materials just to make sure that they're following some of the best practices. Some of the things that, I mean, I'm sure you all have considered before, we think a lot about those readability formulas, but there's coming out with these larger understandability assessments that are really useful because they get beyond just, is my language at the X grade level that I want it to be, but really thinking through how readily the document itself is to understand. Is it set up in a way that really facilitates somebody taking it all in, and also considers the uses of numbers in there. One of the ones I really like is the CDC's Clear Communications Index. We actually formally use that to assess materials in one of our programs, and it was a great experience, I mean, a great learning experience, but quite embarrassing because we had developed materials knowing that we were thinking about health literacy, and we scored horrifically on them, just thinking about the layout of our materials. And it really helped us revamp how we go through and to our participants in our research trials, present information to them. And then also utilize materials that you have effectively. Don't assume materials get read. They're not just something to get passed off. Spend the time to review them with the patient or have a member of your team review with the patient. And then when reviewing, actively engage with the handout. Highlight key sections, circle them, utilize teachback as you're reviewing the paper. Recognize that the paper, if the paper is important or that you're utilizing that material, refer back to it in future visits. But then also make sure patients know how to use or access the information if the materials that you are pushing them towards happen to be electronic. I know I'm a new parent, and as I was meeting with my pediatrician for the first time, she was recommending a very specific website to go to, and even thinking through, so if you're moving your patients to kind of utilize different websites or different applications, just making sure that they know how to use them. Encourage questions, invite questions both directly and indirectly. Asking them if they have questions. Not all patients are able to articulate questions, and I can say that that's definitely me as a patient. Some of the times I, however, has developed the reflex of asking the provider if there's a question that I should be asking them, because sometimes I feel put on the spot. Or also indirectly asking questions. I know one of the things that I tend to do when I'm in the shoes of the one transmitting information is saying that I know sometimes I can't be clear. Is there anything that you would like me to clarify for you? Or is there anything that we need to build on, and kind of humbling myself a little bit in there, and not doing it falsely, but doing it to really just say that I know that I'm not always able to communicate clearly. If you do have patients who come in with a ton of questions, really helping them prioritize those questions. But also, while you are encouraging questions, really be mindful of your body language. Use your body language to show that you have the time to answer and take in the questions, which really involves looking at the patient and giving them that time. One comment came up through the chat that there are built-in assumptions that patients are aware of things that they may not know. And really, yeah, exactly. Trying to help and not make assumptions about what the patient may or may not know. And Deirdre, if there's anything else that you'd like to chime in on that, if you have an example, feel free to.
Well, no, just in that video, when the doctor said to the gentleman, "Are you having any side effects?" My first thought was, does the patient know what side effects that he might expect to have from this? Has anyone educated him on this? And that's a question that we ask patients all the time. You're having side effects. They don't know, they may not know what to be even looking for in order to report on them. So, you know, we get used to using clinical language, and I think we have built-in assumptions a lot of times that patients understand what we're talking about.
And that may be a really good way too, if we think through kind of utilizing written materials, that if someone is getting a new medication, really being able to have something very clear that talks about these are the potential side effects, and I will be bringing these up with you at your next appointment. It might be a way to really bring these two things together. I know the only time I usually see side effects from medications are when I get the pill from the pharmacy, and I don't read that, because even for me, that is incredibly overwhelming. Another thing that is incredibly useful are making action plans. And that actually has been my reaction to watching this health literacy video a few times, is that he is verbally going over the provider is verbally going over a medication shift with his patient, and none of it's getting written down. And kind of saying like, this is what I'm going to do, and just assuming that it's all being taken in verbally. And we know that action plans are one of the most effective behavior change techniques that are out there. And so thinking through with your patients, are there ways to create plans with patients that include their motivations potentially for making the changes? There's a big difference between asking somebody to exercise more and somebody to take an asthma inhaler more regularly. And just trying to figure out why they would want to do it. One, you might need a lot more intrinsic motivation for what are the goals that they want to do? What's the behavior you want them to engage in? What are the steps potentially? What are the strategies for overcoming barriers? Creating a process potentially to track progress. How would someone know? I mean, just thinking about the gentleman in the video, if he's taking 2 of those pills in the morning, how is he making sure that he's taking 2 every morning? If he's been taking 1 for so long that it might have become sort of a rote process for him. Making sure that these plans are written out versus just talking it through, and makes them much more realistic, but also letting the patient drive the formation of the plan. And this latter bullet's really important if it is a true behavior change. So if you're working with a diabetic patient and you need them to engage in more physical activity, for example, it's more of a behavior change than a medication change, letting them do that, because they're the ones who really know their lives and can set the steps that really make, and the goals that make the most sense for them. And then this gets towards one of the comments that was brought up very early on how insurance and other things can really impact navigation. And really this idea of how are we able to direct to medical and non-medical resources? Because that's an incredibly important part of also promoting health literacy, and something that can be done to an extent at like a true individual level, but is something that really needs to be thought about a little bit more in that bigger sense of the U. But trying to be able to assess patients' needs, both and their support systems, including challenges to those, so that those challenges can be documented, and potentially finding ways to address those challenges. So things like being able to pay for medicines, their food security status, literacy, just because we are talking about health literacy, and then really being mindful of their insurance, both do they have insurance or not, but also where can and who can their insurance take. I've recently had a family friend need to have her daughter referred to an outpatient facility related to mental health, and the facility that they were sent to did not take her insurance at all. So even just trying to scramble, and this is someone who is relatively health literate, trying to, and good at navigating the larger healthcare system, trying to navigate to figure out, well, was there a reason I was pushed here and I should kind of follow through with it, or like kind of what's going on, and how can I get something that can be both financially possible and make sure my daughter's getting the care that she needs. And then thinking through with that, how can community resources be identified either that can directly provide those ways to solve those challenges, or are there community resources where folks can be referred who are actually able to help them navigate that process themselves, and also figuring out those pathways to connect patients with resources. The next section we're going to be talking about is a little bit more around some of these ideas around organizational health literacy. But before I jump into that, were there any other thoughts or points with what we've been talking about so far? Okay. And so when we think about becoming a health literate organization, the Institute of Medicine has identified these 10 attributes that really form the foundation for a health literate organization. And so when we think about organizations, we think of something very large. We think about Carilion as a whole, but there are also things that you can do within the training program or within your own clinical units that you can actually take some of these traits and actually embed them into those practices. And the ones that really stand out to me are this idea is that the leadership promotes health literacy. So it's something that's integral to the mission structure and operations. For example, it could become a key way that you're training your group of learners. It prepares the workforce, and this ties directly into that, prepares the workforce to be health literate and really monitoring the process of engaging in that. Strive to meet the needs of populations with a range of health literacy skills while avoiding stigmatization, really embedding those health literacy universal precautions in there. And then utilizing health literacy strategies pretty much consistently and really being able to assess when they're being used and how they're being used and having an open dialogue around them. And so some of the things that are in this toolkit that can really help support this are raising awareness of health literacy, forming and engaging a health literacy focused quality improvement team, finding means to elicit patient feedback. We've already talked earlier about ways to assess whether or not the patients feel that their health literacy needs are being met and to actually assess the providers. And then there's other larger things that are in here as well that the system could consider. Strengthening protocols for follow-up, strengthening telephone access, strengthening the practices by which patients are welcomed into the clinics, and strengthening referral processes. And a lot of this all ties back together with some of the other pieces that we've been talking about. But I also wanted to, within this context, kind of share some resources, because obviously at the individual level, this Health Literacy Universal Precautions Toolkit is incredibly useful, but thinking at a larger, becoming a health literate organization, the 2012 IOM Roundtable on Health Literacy, their summary, which is very easy to find through a search, has a list of actions per each of these 10 attributes. And then within AHRQ, they've also organized one of their pages around these 10 attributes and actually have clickable resources that can be clicked on to then start being able to engage. But then also just knowing there is so much time and effort that goes into making these changes, and that support is often needed. NIH has a number of announcements related to health literacy within the context of health services research that can be applied for. And they really do, a lot of it's related to the R-level grants, but they're out there. But then also, I don't know how many of you received the I Thrive emails, but just literally this morning, their next round of grants came out. And it could be that if like health literacy was something that's incredibly important to you, is this a way to look at improving health literacy practices and thinking through one of those clinically or those translational grants? And so I think if this is something that winds up being important to you guys as a big U or even as a little u, there are resources to support moving forward. So one of the things I was hoping to have for you all today was sort of an own action plan to help you move forward. But just want you to really think about how you plan to put what you've learned about health literacy and health literacy practices today into action. Is there going to be a takeaway and an action step for you from that? And with all of that, thank you. And I will put my video back on, and I know we only have about 6 more minutes, but if folks have any questions that we can kind of finish out the session with.
Dr. Farrell dropped a little message in the chat that more details on these iThrive grants will be in the research newsletter coming out tomorrow. How timely.
It was, I looked at my email this morning and I was like, this is like literally perfect timing. Because that's one of the things I feel like health literacy is so important in how we engage in it and making it systematic, but it does require a change of practice and it does require time. And that's something that we don't always have a lot of, and we can make more of it when there's something to cover some of our time in doing it. Are there any questions or thoughts or things that folks would like to know more about that I could send Mariah or Sherry after this presentation?
Feel free to either type them in the chat or unmute yourselves. Well, do not hesitate to contact us and we will put you in contact with Dr. Porter or get your questions to her if need be, questions, comments, any requests for additional information, and I'm sure she'll.
I just put my email in the chat too, so folks can definitely email me directly.
Wonderful, thank you so much.
This is Sherry Hartman again, here in psychiatry. I thank you for this presentation. The content was so important. I wondered if anybody knows of a resource at Carilion that we could turn to check on our understandability and readability of materials that we're developing.
That I'm not sure about. It's possible that in the marketing and communications, they might have resources, but I'm not sure. Beyond that, that is something that we should look into.
I agree with Sherry on that. I think that that we really don't have that area. And I think Dr. Porter was talking about having a quality, an area within quality that takes a look at that. I think it would be really helpful. And while marketing is good, they're not clinicians. And so they may not be able to really understand and know either. So it is an area that I think that we could develop within, a gap at Carilion that I think we could develop.
Actually, Carilion, this is Dr. Bafboni, and Carilion has Eric Solinger, who is a manager for patient and family education and does review clinical documents for patient level sort of, so that the language is translated into a language that the patient will understand. We use them for many of our educational things. So I think that's an area we can use.
That's great. Is that accessible for the entire organization, that gentleman?
He's Carilion Clinic, so I presume.
Great.
Could you put his name in the chat? I've never heard of him.
And actually, just piggybacking on that, this is Bankole. We're not actually allowed to change any patient material except you go through that office. So if you make any change, you are meant to submit it to them. They first check to make sure legally there's no issues, and then they check the reading grade so that it's set at, and I can't remember what grade it is. I think it's like 6th or 7th grade level or something like that. And that's what he does. So anytime you have a letter you want, it's like a template letter or patient educational resource that you want, that's where you're meant to send them to. And he does do this work.
Thank you so much. Do you know what his office is called? Or is he
it's patient educational services or something like that.
Dr. Bafabani just put it in the chat, the office, the name, and contact information.
Wonderful. Perfect.
The other thing, just because I work with students so much, like, I don't know, just as Carillion's growing with I know obviously this is not a medical student thing, but if there's other groups that could do it, like this would be a very interesting, like, master's level project, and even just having somebody kind of go through and do just a QI and then be able to start that process, like using something like the CCI to do it.
That's a great idea. Okay, we're right on the hour. Don't hesitate to contact Dr. Porter or go through us and we will contact her on your behalf. If you have any other questions, concerns, comments, that'd be great. I hope you all have a wonderful rest of the day.